because when there is a calcified lesion, it makes it difficult to track a balloon across the lesion to dilate. Also, taking a stent to the lesion becomes very difficult, and because of the calcium, the stents don't expand well when you dilate also, which leads to underexpanded stents with suboptimal results. And these underexpanded stents can get stent thrombosis and increased restenosis also. So these are the problems which we have with calcified lesions. How do we identify the calcium? One is by CT angiography if they have had. Otherwise, the fluoroscopy itself will show the calcium, and then we use intravascular imaging with either intravascular ultrasound or OCT, optical coherence tomography, both of which we have here. So we have several tools to deal with these calcified lesions. One is balloons, one is cutting balloons, then rotablation, intravascular lithotripsy like what they use to break the renal calculi, and laser also for uncrossable lesions. And all these tools we have in our cath lab. Now we look at these devices through some case examples. This was an 84-year-old lady who had chest pain with ST depression. Troponin was positive, had good LV function. She had previously been treated at Mount Sinai Hospital where she had angioplasty to left main LAD and LCX, and imaging, rotablation, etc. was used during the index procedure. And then we use a cutting balloon. A cutting balloon has blades in the balloon which helps to open and create cuts in the calcium, thereby aiding stent deployment. This is an example of a cutting balloon. You can see here there are blades on the balloon, which when we open the balloon, the blades cut through the calcium. There are 3 to 4 blades on the balloon, and when it opens, the calcium gets cut. So this was after cutting balloon. You can see now there is a good lumen. And then because already there was a stent, instead of putting another stent, we used a drug-eluting balloon which releases drug into the wall and helps prevent restenosis. So this case we got away by using a cutting balloon, and this was the final result. Now the next case, this 82-year-old male, again had previous angioplasty to right coronary artery. He had severe angina, and you can see here the severe calcium. You can see even fluoroscopically, you can see the right coronary artery even when the injection is not there. You can see the whole right coronary artery, and there's a severe stenosis in the beginning which could not be crossed with a balloon because of the degree of calcium. There's almost no flow. So we decided to do a rotablation in this case, because you need something to go through the calcium. You have to burr and drill through the calcium before we can deploy stents. So we put a temporary pacemaker because it was a right coronary artery, and then lesion was crossed with a regular wire, but we need a special wire to use the rotablator which would not cross. So we used laser to create a channel so that then we could get the rotablator wire across. So we now got the rotablator wire across, and we started burring with the rotablator. This is a 1.5 burr which rotates at about 150,000 to 200,000 RPM, and there's a diamond crystals which help cut the lesion. And as you can see here, we are trying to go through the lesion, but it's difficult. This was after 5 runs of rotablation. You can see there's difficulty crossing that mid part of the lesion. Some channel has been created. This after 5 runs. Then we increase the speed to 190,000 RPM. You can see here, finally it goes through. So we are able to burr the lesion, and we did some polishing runs. You can see now the burr goes through freely, and then we deployed a stent distally and another stent proximally, and this was the final result from where we started. The other tool which we have is intravascular lithotripsy. So one was cutting balloon, second is rotablation. Third tool which we have is intravascular lithotripsy. This was a 80-year-old gentleman who again had chest pain, previous stenting done. He presented with an anterior MI. and you can see here on top the LED is completely occluded. This was at 4 o'clock in the morning. This was a primary angioplasty. We crossed and dilated the lesion, but as you can see here, we put a stent, but there is a chunk of calcium sitting there which prevented the stent from expanding. You can see here, if you concentrate on this part, I'll play it again. You can see here the stent is not expanded at that point. So we tried dilating at high pressure with balloons, but still it would not give way. We are not able to. There you can see there is a chunk of calcium sitting there. The stent is not fully open there. So then we used intravascular lithotripsy. With the help of a guiding catheter, we brought the lithotripsy balloon down. And using lithotripsy, we were able to expand the stent. You can see there with multiple pulses of lithotripsy. We're able to expand the stent at that point and break the calcium. Here the calcium is fully open, stent is fully open, and this patient is doing well. This was the final result. So these are the three tools which we have. This is how intravascular lithotripsy works. It uses shock waves. So there are emitters in the balloon which helps. So this balloon helps to You can see here the sonic waves create about 50 to 100 atmospheres of pressure, and it's able to crack and break the calcium. You can see the cracks in the calcium which happen. So subsequently we can expand with the balloon and deploy the stent. Another case where we used the same IVL. This was inside the stent. There was extensive calcium, so we were able to use intravascular lithotripsy again to crack the calcium and get a very good final result. We can use optical coherence tomography to see the inside of the vessel, to see the calcium pre and post procedure. And this patient, we used IVL. The stent was very well expanded. As you can see here, you have a circular lumen. The stent is very well expanded and well deployed. And this was the stent, and on the right you can see the final result. This is again the OCT finally showing good expansion of the stent, as you can see in the bottom. So we get a lot of calcified lesions now with elderly populations. Unless we prepare the lesion well, if we under deploy the stent, we can end up with problems with stent thrombosis and restenosis. Hence we have all these array of tools like cutting balloon, rotablation, laser, intravascular lithotripsy. All of these help to break the calcium, prepare the vessel well, and help us to deploy the stent well. So this is a difficult subset to treat. CABG is also an option in these patients, but again, a lot of them are elderly, as you saw, 82, 84, where surgery also carries its own risks. So we are able to deal with all these calcified lesions with all the tools which we have now. Thank you. Clinically, we cannot make out. So one is CT angio. Fluoroscopy during the angio shows the calcium. So these two tools are usually used. During the procedure, we use intravascular ultrasound and OCT. See, most of the elderly will have calcium, but we will be doing, when we do the angio on fluoroscopy, we can see the calcium. If we see significant calcium on the fluoroscopy, then before angioplasty, we have to go prepared to use one of these tools. Can happen, sir. If the calcium is mainly on one side of the one wall of the vessel, if you are dilating at high pressure, the hard portion will not crack, but the opposite wall can give way. This can cause dissection, rupture, perforation can happen.
You are employing 18,000 revolution.
180,000.
180,000 rotations per minute or second.
Per second.
And 100 atmospheric pressures.
100 atmospheric pressure is with the lithotripsy balloon. What we saw, that shockwave lithotripsy.
What are the chances of rupture of the vessel itself?
See, because it's a calcified lesion, you're using controlled pressure, so chances of rupture is about 2%.
Beyond the calcification, the vessel exists.
Yes.
Can this pressure
There's
extend
intima,
to that
media,
vessel?
and adventitia. So the pressure starts in the intima, cracks the media and adventitia lesion also. But if you oversize the balloon, instead of using a correct size balloon, in a 3 mm vessel, if you take a 3.5 mm balloon and do this, you can perforate the vessel.
And the calcification is always confined to intima or media,
no,
never to adventitia.
It comes everywhere.
The muscle.
Railroad appearance.
These are okay when you have a focal calcification. So you have diffuse calcification. What's your take on this?
See, if the distal vessel is good, you can still do rotablation even in long lesions.
So for it prevents CABG.
See, it's two things happen. One is age, like in these patients, and second thing is patient preference, because lot of patients want a interventional procedure now and not CABG. So that also comes into focus. See, usually if they have multiple risk factors, then yes. If there are no risk factors, just as a routine, I don't think there is data. But in patients who have multiple risk factors, yes.
But is it recommended
With CT calcium scoring, yes, in multiple risk factor patients is indicated. No. Yes. See, if the suspicion of disease is very low, then CT angio is okay as a screening tool. See, somebody with recurrent chest pain, risk factors, but treadmill is negative, you just want to rule out coronary disease, then CT angio is a good tool. But in somebody who has typical symptoms, somebody has a positive treadmill, in that patient I wouldn't screen with the CT angio, I would go for a regular angio.
See, this coronary bypass surgery and PTC are not competitive, they are only complementary. And we must remember that both are only palliative, both of them are only palliative. Only the medical treatment and your prevention will carry the day for the patients, for all of us. Okay. Very good presentation, Balaji. Good.
During rotablation, yes, because we are pulverizing the lesion, creating small particles, so it can cause distal slow. These particles have to get washed away in the bloodstream. That is why we rotablate for 20 seconds, wait, give nitroglycerin flush during the rotablation, so that the particles get washed away, but still you can get slow flow. It is less with intravascular lithotripsy. See, carotid calcification, they don't, because here the small particles which go distally, we can get away, get washed away. In brain, that risk you cannot take. That is why calcified lesions, they advised endarterectomy rather than stenting.
Very true. As pointed out by Dr. Asogan, atherosclerotic disease is a metabolic disease. These are only mechanical complications, like your blocks, all those things are mechanical complications. So, all these procedures attempt to clear the complication of the disease, but the true disease is ubiquitous. It is present everywhere, not even in the abdomen, in the sun. So, we must address the basic disease in the long run. Thank you.
Ramakrishna also writes, if you see peripheral vascular disease equal to coronary disease. Thank you, sir, for a very nice presentation. Over to Dr. MANOHARAN, sir, for his presentation.
Nitya has joined us as a Depend B cardiology PG. She is from this part of the town. Her father-in-law is known to Dr. Asogan and Dr. Rajiv Paul. She will present the case.
Good morning, everybody. Here I am going to present a case of ST elevation in ECG mimicking acute MI in a patient with acute cholecystitis. So, this case is a 60-year-old gentleman. He came with complaints of fever for 2 days, along with loose stools for around 3 to 4 days, and associated with diffuse abdomen pain. So, at arrival, the patient was conscious, oriented, and afebrile. On examination, the patient had diffuse abdomen pain on palpation without any guarding or rigidity. Other systems examination was unremarkable. On examining the vitals, the patient had tachycardia and BP was on the lower side of 80 systolic and 60 diastolic. Otherwise, he was not hypoxic. So, doing the labs, we found that the patient had elevation in the total counts, around 15,480. His random sugar was 302. He had jaundice, and there was mild elevation in the liver enzymes. His procalcitonin was significantly elevated, which was 4, indicating some sepsis in the patient. So, on the day of admission, ECG was done, which did not show any significant changes in the ECG. So, imaging was also done. Ultrasound abdomen showed gallbladder sludge with gallbladder wall thickening, suggestive of subacute cholecystitis. So, we can see the picture of the ultrasound abdomen showing distended gallbladder. And MRCP was done, showed distended gallbladder with sludge and diffusely thickened wall, which was also suggestive of acute cholecystitis. So, this is the MRCP picture showing the distended gallbladder. So, after that, on day 3 of admission, the patient again had some complaint of chest pain intermittently. So, ECG was repeated again on day 3. So, the day 3 ECG showed some ST elevation in leads 1, 2, AVL, AVF, V5 and V6. So, you can see mild ST elevation can be seen here in AVL, AVF, V5 and V6. So, then echo was done, which did not show any regional wall motion abnormalities, and the LV ejection fraction was normal. Troponin I was done on the day of admission, which was negative, and on day 3, along with the ECG changes, we did a troponin, which was significantly elevated up to 16,838. So, the patient was taken up for coronary angiogram in view of the ST changes in the ECG along with elevated troponin. So these are the angiogram pictures which showed normal coronary arteries. There was no occlusion or any significant stenosis. So the patient was managed with IV fluids, IV antibiotics and supportive drugs, which with the patient became alright. So what could be the reason for ECG changes in cholecystitis in this patient? So generally, there might be a coronary vasospasm which is caused by the vagally mediated reflex, which is a cardiobiliary reflex, which can result in bradycardia and other non-specific ECG changes, but usually not ECG elevation. And then ST elevation in the ECG. Then sympathetic nerve stimulation is demonstrated in the animal models with distended gallbladder. So both the heart and gallbladder shares the same sympathetic thoracic segments T5. So this reflex coronary artery vasoconstriction can occur in patients with distended gallbladder and result in transient coronary artery occlusion, which can cause the ST elevation in the ECG. So the other theories, ECG changes may also be evoked in response to inflammation of other visceral organs, that is like because of the sepsis. And the other mechanism is the anatomical proximity of gallbladder to heart. So the local inflammation of gallbladder in cholecystitis can cause to irritation of diaphragm and the inferior myocardial wall. So this affects the myocardial tissue due to its close proximity. The irritation might produce ST elevation in ECG, predominantly in leads representing inferior and infralateral wall, as in our case. And troponin I elevation in cholecystitis is also because of the cardiobiliary reflex, as we saw on the last slide. And gallbladder distension may lead to elevated blood pressure and increased heart rate, along with increased renin secretion. So with increased heart rate, we know that the heart gets its blood supply during the diastolic phase. So when there is tachycardia, usually the systolic phase remains constant and the diastolic duration is decreased. So this might cause a decrease in the blood supply to the heart. And the last one is the systemic inflammation associated with septicemia. This also claims to be responsible for elevated troponin. So the possibility of simultaneous MI in a patient with acute cholecystitis is to be considered, where the patient will need antiplatelets and anticoagulants or or the patient might need a thrombolysis. But in case we are going to give the patients antiplatelets, anticoagulants or thrombolysis, if the patient warrants a need for surgery for the cholecystitis, then there is an increased risk of significant bleeding in this patient. So it is always wiser to go for coronary angiogram before giving any cardiac drugs to rule out coronary artery disease. So what could be the causes for raised troponin levels? So myocardial injury is defined as troponin level of at least 1 nanogram per liter above the 99th percentile upper reference limit. So troponin elevation could be both because of the acute myocardial injury or the chronic myocardial injury. So coming to some causes of acute myocardial injury, where the troponin could be elevation, it could be either cardiovascular causes or the non-cardiovascular causes. Cardiovascular causes are, as we all know, it is acute myocardial infarction, then hypertensive emergencies or urgencies. In patients with acute heart failure, pulmonary embolism, acute aortic syndrome, any cardiac interventions including PCI, ablations, or any patients post cardioversion or defibrillation. In patients with the myocarditis, myopericarditis or endocarditis and arrhythmias, all these patients can have raised troponin levels. And non-cardiovascular causes are sepsis, which is what probably caused the troponin elevation in this patient. Then acute renal failure, any critical illness, non-cardiac surgeries, stroke, extreme exercise and false positive results can be seen. And causes of chronic elevation in the cardiac troponin, the cardiovascular causes could be stable coronary artery disease, chronic heart failure, hypertension, any valvular heart diseases, cardiomyopathies, pulmonary hypertension and left ventricular hypertrophy. And the non-cardiovascular causes could be chronic renal failure, skeletal myopathies and cardiotoxic medications. So just a slide on the types of MI. Type 1 MI is a spontaneous myocardial infarction due to plaque erosion or plaque rupture, and type 2 MI is secondary to ischemia due to increased oxygen demand or decreased supply. Causes like anemia and sepsis are the causes for type 2 MI. So this patient we had probably the patient had a type 2 MI. And type 3 MI is sudden unexpected cardiac death with symptoms suggestive of myocardial ischemia without where we do not have troponin values. And type 4 MI is MI associated with percutaneous coronary intervention or stent thrombosis, and type 5 MI is MI associated with cardiac surgeries. Thank you. Yes, sir. Okay, sir. Okay. Okay.
Very true. The sepsis is one good possibility because the procalcitonin is
4
quite high.
investigation.
Quite high. See, the moral of the story is, see, when you are working in casualty and you see patient with coming with some abdominal discomfort, chest pain, you see ST elevation. See, you must be very careful. You must not jump and give this antiplatelets or heparin or whatever it is. If you are doubtful, do an ultrasound to rule out cholecystitis. Sometimes it could be dissection, it could be pulmonary embolism. It is not always MI. ECG changes can be there in other problems also, especially if you are dealing with acute cholecystitis and you give antiplatelets, because we immediately give antiplatelets in the casualty. So the operation, it is nightmare for the surgeon who is going to do surgery. So you must be very careful and take a proper history and think other possibilities. Do some lateral thinking and before embarking on treatment, try to rule out all these things. That is very important. That is the importance of presenting this case. Not to jump into giving antiplatelets whenever you see an ECG with ST elevation. Thank you.
If you have diagnosed with the abdominal stethoscope, namely ultrasound scan, this is a case of acute cholecystitis, would you have ventured into a coronary angiogram?
Sir, we knew, but with the troponin of 16,000, we generally don't see that much elevations in troponin, sir. So that was one reason why we took up the patient for angio.
Associated MI, if the person with cholecystitis, he has an acute coronary occlusion, and if you delay the treatment, you will be taken to court. And suddenly, if he dies, see, MI, they can die also. So before giving antiplatelets, you do the angio first instead of the other way around. Normally in acute MI, when we do primary angioplasty, we give antiplatelets before we start the angio. Here, when you are doubtful, you do the angio first and rule out or rule in, then treat the. Suppose if it were coronary block, you would have definitely forgotten about the cholecystitis. You would have saved the patient and then referred the patient for surgery. See, the problem is whether there is associated coronary problem, which oversees the coronary if it is present. So the idea is don't give antiplatelets in a hurry. That is the.
Very good presentation from Department of Cardiology. If there is no other questions, we can conclude the meeting.